Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, a topic I'm surprised I have not covered yet, but it's going to be on hyperangulated laryngoscopy, tips and tricks for mastery. And I bet even if you've been using this device for years, you'll get at least one or two tips that you did not already know that will change your practice. If not, I will refund your full money for this episode. So it's weird, I'm jumping the gun on this because very soon it will be January, that I believe I coined that term, and I should be doing this then, but I just can't wait. I just wanted to cover this. So hyperangulated laryngoscopy mastery. And I am old enough in the profession to remember when video laryngoscopy had first come on the scene. We had learned direct laryngoscopy with McIntosh and Miller's, and now there was this new video device, and we all wanted to get our hands on it. Now, the only video devices out there were the GlideScope with a hyperangulated blade. That's all you got. If you went video, that's what you got. And this device, it looked like it was going to be amazing. All of a sudden, you have views on a screen, and we were all super excited. And then you started hearing the stories. Now, luckily, I was never witness or party to any of these, but I heard the stories from our program and programs all across the U.S. and case reports in the literature of pharyngeal trauma. Never had a part of that. But what I did see, not uncommonly, was you'd have this amazing view of the cords, and you just couldn't get a tube in. And you just like, what the hell's going on here? A lot of people went back to direct, and it's because there was no training for the specificities of this technique in contradistinction to what we already knew. Our program never got any training. We were never told, this is really different, here's the ways to do it. And people since then have given beautiful elucidations of the actual way to do this technique. And I think as a profession in emergency medicine and critical care, we've gotten much better with hyperangulated laryngoscopy. But I know there are still residency programs out there that just aren't teaching this with the full breadth of knowledge you need to optimize this technique. So that's what this podcast is an effort to do. Now, I had already had this in the hopper with the way I build episodes, just to reveal the behind the scenes, is anytime I get an idea for an episode, I create a page for it on the site in draft form. And I just keep adding all of the tips and articles and papers and things that I come across. And so Hyperangulated was already building this little storage of things I wanted to talk about. And then I think about 8 months ago, I came across a video by Nick Crimes. Nick is an Australian anesthesiologist. He's a former of numerous airway societies. He's just doing great stuff. You'll know him from SMAC, and he's the creator of The Vortex. And Nick was doing a video series for the Safe Airway Society called Airwaves. And Airwaves number 3 was on hyperangulated video laryngoscopy. And as his guest, as the expert he brought on, was Professor Richard Cooper, who is brilliant. I knew him from the Society of Airway Management. He's a Canadian professor of anesthesiology. He's numerous accolades for airway management innovations and just an amazing guy. And the two of them, for like an hour and 10 minutes, just talked about hyperangulated video laryngoscopy. Now, I've linked the full video in the show notes for this episode. But in addition, and hopefully, Nick, if you don't like any of this, I will take it down, but hopefully you won't mind. What I've done is I've gone through the entirety of it and stolen, minute-long video clips that I've actually excerpted. So if you don't want to watch the full hour and 10 minutes, which I think would be well worth your time, though this episode is going to cover pretty much everything in there, then you could actually see the video clips that will go along with what I'm saying that'll make it all make a lot more sense. So we're just going to go through the procedure in the order that you're actually going to do it in, and then we'll discuss some other maneuvers afterwards. We'll discuss some controversies on whether bougies should be used with hyperangulated, and then we'll see where that all goes. So let's roll. All right, so hyperangulated video laryngoscopy. Now, I'm assuming you're either using a GlideScope or a CMAC. Both of them have hyperangulated blades, slightly different in shape, but basically, for all intents and purposes, the same. And I believe that the McGrath has readily available hyperangulated blades as well, but I don't play with the McGrath, so I'm not going to speak to that specifically. I'm sure everything I'm saying would work with that hyperangulated system. I don't recommend or like the channel devices, and so I'm not really going to discuss them at all in this episode. So we're really just talking hyperangulated blade, and with the key being on a hyperangulated in contradistinction to a standard geometry, you're reliant on the video screen on these. That's what makes them different. You get a nicer view. You can see around a corner, but you can't look in the mouth and expect to be able to visualize glottis. It's a double-edged sword as a result, because fantastic ability to get views in airways that may be difficult with standard geometry, and yet if the camera gets splooged out by vomit or secretions, you got to come out and clean it. You can't just use the video device as a direct. That's the trade-offs from hyperangulated. Let's start with preparation. Patient positioning. They could be a lot lower than they are for standard geometry because you don't need to look in the mouth to see the glottis. So the patient does not need to be high up like they would for standard geometry. And you should be standing up straight. You shouldn't be crouched over. The ergonomics are such that patient's low, you're standing up straight. Positioning. Now, my personal opinion, and this was Nick's as well, is you should do the same optimal positioning you do for standard geometry, and that would be that the sternal line is at or above the level of the external meatus, not the sternal notch that will send you astray depending on the patients, whether they're flat or semi-recumbent. So sternal line, that's the imaginary line from the xiphoid to the manubrium, and that line should be above the external auditory meatus with the face plane as parallel to the ceiling as you could get it. Now, Dr. Cooper points out that if you're having trouble getting the blade into the mouth because there's first the blade itself and then there's also wires extending out of it. And some patients with a big chest, pregnant patients whose entire chest is pushed up, some of those patients will have trouble getting it. In that case, putting the patient in a more neutral position will actually give you more space. Now, I actually don't bother with that. If I can't get the blade into the mouth because the wires are impinging on the chest, I just rotate the blade 45 or 90 degrees, do most of the insertion towards the base of the tongue that way, and then rotate the blade back to its normal position. And that prevents those wires from pushing against the chest. But Nick's point and my point is if you position these patients well, when you have to do rescue maneuvers, you're going to be a lot better off for BVM, for placement of supraglottic airways, and for if you have to revert to a standard geometry blade. So for all those reasons, that positioning is nice. You can argue that a neutral position would be more optimal, avoiding neck extension, because it does make the tube a little bit easier to get into the trachea. But for the reasons I just mentioned, I like to do the same positioning for hyperangulated as I would for standard geometry. I want to have a tube with a stylet, and we'll talk in a second about what that stylet could be. If you're using the rigid stylet from either Storz or Verathon, the Glide Right stylet, you should lube it because it's very difficult sometimes to pull it out easily. If you're using a non-slick malleable stylet, you should lube the stylet. It's a more angulated shape. So even though you might not have a problem pulling a stylet out without lube in the standard shape, this shape, it's easier with the lube. Now, if you have a slick malleable stylet, then you don't need to lube it. This one was new to me from the video, and it might have saved me from one problematic intubation. Dr. Cooper advocates lubing the top of the blade, and not just for hyperangulated. He does this for all laryngoscopy. And I did have a situation where a patient was so dehydrated that their tongue was basically like flypaper, and it became a real pain in the butt to be able to move the laryngoscope. And if I had to lube the blade in that case, it would have been easy peasy. So he does this in all his intubations. I think that's great. Dr. Cooper mentions, and I don't have much experience with this because I am a Storz player for most of my career with the various CMAX systems, but he says for the glide scope, he prefers a 3-blade in almost every adult patient, a smaller blade, unless they have a very long jaw, very long mandible, in which case he'd go up to a 4. And his rationale is it just sets the camera location in proximity to your glottic view at a better location for most patients. So he would err on the side of smaller blade if you could reach rather than larger blade. With the CMAX system I use, it's not really relevant. There's only one size hyperangulated blade, one size fits all, and I haven't had a problem with it in any size patient. All right, let's talk tube shaping. Now, if you look at the stylets manufactured for this purpose by Verathon and Storz, you will see the distal third of the stylets match the hyperangulated curve of the laryngoscope, and then it goes straight on the rest of the tube. If you have these stylets and they don't disappear on a constant basis, then you could use them. Again, make sure to lube them. But you really don't lose very much at all just using malleable stylets when molded to the right shape. And the shape description by Dr. Cooper is a droopy J. Now, just to articulate that in more precise terms, if you look at the Glide Right stylet, it has a 70-degree bend starting about 8 to 10 centimeters from the tube tip. That's right about where the tube number markings are on most of the tubes I've seen, where it says 7.5, 8, 0, etc. And so that distal third gets a gradual, gentle bend to 70 degrees. This has been described as a hockey stick. I don't really think it looks like a hockey stick. Hockey sticks are straight to the cuff and then have the bend. That's Rich Levitan's description of what you should do for standard geometry. These don't quite look like a hockey stick to me. I like the droopy J better. It's just a perfect J where the very end of the curve has straightened out. That would be the ideal shape. What we did is on all of our carts, we have or on our table where we set up for intubations, we have a laminated checklist that it just is sitting there underneath on the cart. And I, as a watermark of that, put the shape of the stylet, the Glide Right stylet, there behind it in gray so that it doesn't obscure the writing on top of it. But you could just lay your endotracheal tube with a malleable stylet inside it onto that piece of paper and bend it to the perfect shape. So it's always right there. So that's another possible tip for you. Now, you'll notice on the Glide Right stylet, the stores didn't do a great job of this. I don't know if this was part of a patent or not, but the Glide Right stylet has a beautiful thumb tab for popping out that stylet at the point we'll discuss shortly. The stores stylet, not great for that. It's this weird kind of oval on top that doesn't really lend itself nicely to popping with a thumb. In addition, the stores rigid stylet doesn't reach the way to the end of the tube. Which might be a bonus, but it does make it a little bit more difficult because it has a tendency to pop out. I would say if you're using the CMAX system, I would still probably want the Glide Right stylets if you're going to buy stylets. But I think it's just easier just to go malleable because then you can just throw them away. But if you're going to use the malleable, put a thumb popping tab in facing you. So you're doing the front bend to get the 70-degree gentle bend, but then at the very proximal end of the endotracheal tube, bend it so that it's facing you with a nice little place that when you push with your thumb, the stylet's going to pop out. People forget that and then have trouble at that point during the procedure. All right, let's talk blade insertion. Well, actually, let's not talk blade insertion.